and having kind of HFpEF-like situation, endopnea, as you lean and you increase your intrathoracic pressure and you get breathless. And then you are out of sugar controls and you don't tolerate SGLT2, which is frontline therapy for HFpEF. Now you are in a fix. This guy needs sugar controls and other metabolic structural functional comorbidity addressals. How would you, and then we know that GLP-1 RAs are getting fast approvals, both for ASCVD related events, heart failure, and also CKD related outcome benefits. So, and then there is scoring, which is a new score by ESC, last year's score to DM, how we risk stratify patient. But this index patient given to us is already a very extremely high risk patient. So I invite my first speaker, Dr. Sanjeev Pathak. This guy needs SGLT2 inhibitor because nothing has tapped the holy grail of HFpEF. And SGLT2 inhibitors are the class 1A indicated drug for this. And now this guy didn't tolerate in previous instances. How we can re-challenge it? Or we have to shift to other cardiovascular benefit, cardiovascular renal beneficial drug class like GLP-1 RAs in this case. And with Dr. Rucha Mehta would be following this. So I invite Dr. Sanjeev Pathak for his deliberation first.
Thank you, Dr. Prashant. Thank you all the chairpersons and moderators and referees and scorers for this talk. And big thanks to Dr. Kamal Sharma and the Cardiocon team for inviting me to address this issue regarding this particular patient. Well, actually, there is no debate because we know that in a type 2 diabetic patient having cardiovascular disease or cardiovascular multiple risk factors, both these drugs, SGLT2 inhibitors as well as GLP-1, have now enough data that there is hardly anything to fight between the two. They actually do not compete with each other. We always say they complement each other. So the debate ends here. And of course, it is not wise to debate with Rucha because no one can ever win a debate against her. So I'm not going to debate. I'll just put my point that which drug should be preferred first, SGLT2 or GLP. Well, we know that SGLT2 inhibitors have over last 10-15 years, ever since EMPA-REG came, it has shown these molecules, both EMPA and DEPA, have now shown that these molecules actually reduce not only blood sugar or the HbA1c, but also are reducing the weight, visceral obesity, as well as the cardiovascular risk factors and the cardiovascular outcomes, especially the heart failure outcomes. And now we have enough data with heart failure studies also that both these drugs can have significant reduction in the 3-point, 4-point MACE, overall death rate, cardiovascular death rate in patients with heart failure with or without diabetes. Similarly, diabetes with multiple risk factors or diabetes with established cardiovascular disease, both these drugs have great data. EMPA-REG has shown slightly better results compared to the dapagliflozin's results in the declared TIMI. But over a period of time, we have realized that both these molecules have been absolutely must, either of these, I would say, to treat a type 2 diabetic patient with multiple risk factor or established cardiovascular disease. Here I have been given a case of 50-year-old male already having cardiovascular disease. He is HFrEF with ejection fraction almost, not HFrEF, rather HFpEF. I'm sorry about that. Ejection fraction is, I think, 55. He is obese. His HbA1c is 8.9. He is developing recurrent balanitis because of SGLT2 inhibitors. He is already on basal insulin plus metformin. So in our country, we know that when patient is on metformin plus basal insulin, insulin is not going to be sufficient. He will need another agent. The most popular agents have been sulfonylurea till now, but now we know that with invention of DPP4 and now SGLT2 inhibitors, we use them along with metformin and if required with basal insulin to reduce the insulin dose and to have overall cardiovascular benefit. The only negative side of SGLT2 inhibitors in practice is genitourinary infections. Well, urinary tract infections we know are very common in type 2 diabetic patients for several reasons. One is the advanced age. Female gender again is a risk factor, but this is a male patient, so we are not talking about that here. Low GFR, patient with proteinuria, microvascular complication, or And apparent urinary tract obstruction like obstructive uropathy also is a risk factor for development of urinary tract infection. On the other hand, genital infections also do occur, especially when patient has significant hyperglycemia and resultant glycosuria. They are more common in obese people, more common in uncircumcised men. They rarely occur in a circumcised man. And uncontrolled hyperglycemia is also a big risk factor for genital tract infection. How do they cause it? We know that SGLT2 inhibitors increase glycosuria. They cause about 70 to 90 gram glucose per day to be excreted, and that's why the resultant calorie loss is about 300 calories roughly, and that's why it causes not only glucose control but also fat loss and weight loss. The incidence of genitourinary tract infections, if you look in the major trials, varies between 1.5% to 3% in different trials. In declared IMI, the incidence is only 0.2%, which is surprising. But over a period of time, we have realized that about 5% of males and 7 to 8% of females develop genitourinary tract infection, especially genital infections, balanitis or balanopostitis. These are different studies. We have our own study which is going to get published, and that's why we have not presented the data here. It's a huge study, pan-India study. The study name is Genius. You would find it maybe in JAPI or one of the international journals in coming 6 months. And there also we found that there are some regional differences, but over the country, the incidence is about 5 to 7%, not that great, in patients who are treated with SGLT2 inhibitors, and 3% in patients who are not treated with SGLT2 still. They also, because of glycosuria, develop genital tract infections. But as against that, if you balance it out with the benefit, you can see that if you treat 1,000 patients with empagliflozin for 3 years, you can have 17 MACE events reduction, 25 deaths will be reduced, 14 hospitalizations will be reduced, and over and above that, there would be favorable effects on the acute kidney injury, hepatic fat, uric acid, new onset obstructive sleep apnea, the list is growing. As against that, out of 1,000 patients you have treated, 53 excess genital infections will be there, no excess complicated UTIs, and this is very, very important. Actually, SGLT2 inhibitors in none of the trials have shown that they increase the risk of urinary tract infections. In our Genius study also, the incidence of urinary tract infection has been 6.3% in SGLT2 treated patients, 5.9% in non-SGLT2 treated patients, so hardly any difference. Urinary tract infections do occur in diabetic patients regardless whether they are on SGLT2 or not, but only because we have started using SGLT2 in more and more patients, probably we have become more aware and more cautious about the urinary tract infections. Having said that, in patients who is developing recurrent severe UTI, one has to stop, or if patient develops chronic pyelonephritis or acute pyelonephritis for that matter, one has to stop SGLT2 without any doubt. So overall, the benefits of SGLT2 exceed the risk, justifying its class 1 level A recommendation. Roughly for every 1,000 patients treated with empagliflozin for 1 year, if patient is having CKD or cardiovascular disease, you are reducing 23 events if patient does not have any other comorbidity. But if the comorbidities are there, the number needed to treat will be even smaller. You can see that you can reduce hospitalization significantly, and there is rare increase in the incidence of euglycemic ketosis. Probably it has been grown out of proportion. The incidence of euglycemic ketosis in patients treated with SGLT2 is very, very rare. Again, having said that, in patients who is severely insulinoponic, this can occur. One has to be careful, but over a period of time, we have seen that this is a rare condition, which is probably over discussed in most of the conferences as well as in the journals. Volume depletion, dehydration rarely occurs with SGLT2, so the only side effect of SGLT2 is the genital infection and not urinary infection. Even if you look at the Emperor Preserved study or heart failure studies, you can see that even in patients who are younger or less than 65 years of age, it can significantly reduce the CV death, overall cardiovascular events, without any increase in the urinary tract or the genital tract infections. And compared to DPP4, this is a very good study that there is no increase in the risk of severe UTI with SGLT2 compared to DPP4 or even compared to GLP-1 analog. So how to minimize the risk? Well, if you are worried about the genital infection, obviously the genital hygiene, both in males and female, is extremely important. We need to explain, we need to discuss with the patient regarding the importance of genital hygiene when you are using SGLT2 inhibitors. So genital hygiene is very important. Adequate hydration is also very important, and avoiding when patient has severe hyperglycemia or avoiding in patients who is hospitalized is probably the key to avoid all sorts of infections. Genital infections are very easy to treat. So re-challenging after giving it for 1 or 2 times is not a big problem. One can always use, unless the patient is having severe genital infection or is having some Fournier's gangrene or something like that, which becomes an absolute contraindication. But that is extremely rare. I have not seen a single case of Fournier gangrene after using SGLT2 in maybe 10,000 plus patients. So treating genital tract infection is mostly through the topical ointment. Very rarely you require oral antifungal, but though in clinical practice we use it sometimes. But most of the infections, they respond to topical antifungal. Dr. Rucha will also agree. So the clinical consideration when you want to re-challenge this patient with an SGLT2 rather than choosing another drug is that you need to be more careful discussing with the patient regarding the genital hygiene, and in case mild infection begins, one has to apply a local antifungal ointment. Just last slide. So the learning points from this case, according to me, obviously one has to calculate the either Q risk or ASCVD or now score 2, and if the patient is high risk, one has to use all these strategies to reduce the cardiovascular events, including the statins or the drugs which have been already discussed. And now we have 2 more anti-diabetic drugs which are very, very favorable for cardiovascular and renal outcomes, that is SGLT2, and Dr. Rucha will be speaking on the GLP-1. I'll stop here. In last 10 years probably, we have started using SGLT2 and GLP-1. I have more than 1,000 patients initiated on GLP. The only problem with GLP is the rate of discontinuation because of either side effects or cost or due to some other perception is very, very high. Out of 1,000, only about 350 patients have continued, so 650 patients have discontinued, roughly. This is a rough ballpark figure. Contrary to that, amongst the SGLT2 users, maybe 5 or 7% may have to discontinue. So at the end of the day, what matters is how long the patient is taking the therapy. With GLP, that is always going to be a problem and challenge. With SGLT2, it would rarely be a problem. Thank you very much. Thank you, Dr. Kamal, and the organizers for giving me this opportunity.
Dr. Rucha.
Good afternoon, everybody, and thank you so much, Dr. Phatak, for that kind introduction of me that I always win every debate, even when I'm not trying to. So I think this is a very interesting topic and an interesting format. Thanks to Kamal for having us. And we find the distance where this doesn't kind of get mad at me. So what we have here, my capable friend, Dr. Phatak, has just told you that there's a 50-year-old Indian male, and I can see many in the room who seem to be 50-year-old male, and he gets balanitis. And it's okay to continue a medicine that causes the balanitis. So any of you who are 50 in this room, and if you get balanitis on a medicine, raise your hands if you're okay to continue that molecule. I don't see a single hand going up, Dr. Phatak. Nobody wants to continue the medicine if they get balanitis because I'm sure it's very, very painful. And even though you have not seen a single case of Fournier's gangrene, that's because the patient stopped the medication. He did not want to go into Fournier's gangrene, is probably what I think. So let's look at the case over here and understand this patient. These are patients we see on a daily basis. An Indian male who is 96 kilograms, wherein we deal with the thin fat Indian phenotype on a daily basis, apparently on optimal cardiac medications with uncontrolled diabetes, and we are only thinking that we will give him metformin, which is going to help mildly, and also a long-acting insulin. and now really try to convince him at this late point in the game for lifestyle modifications. I think certainly we need lifestyle modifications at every point in the game. It's a game changer. But let's see what options do you have. We'll talk about to control his diabetes. How many of you would like to give him sulfonylurea? I think in India we still cannot shy away from using that. So I see a lot of you nodding your heads. How about short-acting insulin analogs? Okay, so GLP-1 receptor analogs. Let's assume he's rich, affording. We even have cheaper molecules on the market. Retrial with SGLT2, all of you already told me no. Pioglitazone. Since you already heard he has HFpEF, you may want to stay away from that. Bromocriptine, some of you may not know it's a medication for diabetes now. And last but not the least, why not just cut to the chase and do a metabolic bariatric surgery? Anybody for bariatric surgery, metabolic surgery? BMI is very high, it's an option. You need to be aware that these are options. It is the only thing that is known to reverse HFpEF. In order to reverse HFpEF, you have to lose the tune of about 20 to 25% body weight. So really depends on what you are trying to achieve. Goal setting should be done based on whether it's type 2 diabetes, fatty liver, HFpEF, what are you trying to work on for this patient, or cholesterol, as we saw in the earlier case. So the agenda is I'll speak to you about GLP-1, though this audience knows a little bit about it. And then how we need to focus not on a glucose-centric approach, but much more on a patient-centric approach, work on inflammation, and the task given to me is cardiovascular disease and nephropathy. And how did these guidelines change along the way, and how should you as clinicians try to approach this patient? So I just promise you, I'll try to not show as much data, but try to decipher the data, that there is something that we speak about now that known as a cardio-renal metabolic risk. Just waiting for the sound to go away. So we know that the common soil hypothesis that metabolic syndrome came from insulin resistance, there is type 2 diabetes, and along the path somewhere, or way before you even got any of this, there was already a soil for developing insulin resistance and heart disease. Ultimately, what kills the patient is, of course, heart failure, cardiac arrest, but what are the risk factors? And some of these are nephropathy, kidney disease, the beginning of proteinuria, endothelial dysfunction, and inflammation. Hence, the guidelines, which used to say start with one medication, call the patient back in 3 months, check the HbA1c, add a second medication, have now changed from just having an HbA1c up here to now saying, does your patient have, it's a busy slide, but I'll just tell you, when you first see the patient, does your patient have ASCVD, does he have heart failure, or does he have kidney disease? And as you can see, the yellow arrows point to the two things I'm supposed to deal with. Is your patient obese? Then certainly think of GLP-1 receptor agonist. Does your patient have CKD? Then you need to think of SGLT2 or GLP-1 receptor agonist. So it is sort of compelling to you, if your patient has any of these underlying things, you need to think about these two molecules. And I'll quickly just show you the numbers you need to remember as clinicians, that the oral GLP-1 agents are available to us in the market. Of course, when we only had needles, it was always tough. In India, a needle is a needle. Patients want to stay away from needles, but now that we have these oral molecules available to us, in comparison to empagliflozin or SGLT2 inhibitors, they cause a 24% greater weight reduction. So remember, our patient is 96 kilograms. They also help in reducing waist circumference 31% more, which would reduce the visceral fat and hence reduce inflammation, which we know is linked to the metabolic syndrome. Of course, they offer superior glycemic control to oral semaglutide in comparison to empagliflozin, almost 63%, and 7 out of 10 patients will achieve an HbA1c less than 7, and that would be the goal in somebody who's 50 years old, as is this patient over here. Now, as far as CV benefits go, we know unequivocally from the trials that we have at hand, so in the future we might see different things, that as far as MACE reduction and ASCVD goes, the GLP-1 receptor agonists are far superior to SGLT2. But in the case of hospitalization for heart failure, so far, the data is in favor of SGLT2 inhibitors. Oral semaglutide, these are the results from the Pioneer 6 overall summary. As you can see, similar population to our patient, age about 50 years, with or without established CV disease or high risk for CV disease. And what you can find is there was a 21% risk reduction versus placebo, even though non-significant, in the favor of oral semaglutide. Now similarly, just to show you very quickly what we are talking about, the kidney outcomes. So up top over here you have the risk of progressing to macroalbuminuria, and the bottom you have the risk of progressing to end-stage renal disease. This is GLP-1 versus placebo, and you can see across the board these molecules do pretty well when you compare them to not giving GLP-1 receptor agents. So you want to be thinking about these molecules early on. Now, also we know that from trials that oral semaglutide reduces systemic inflammation as measured by HSCRP, as shown over here, by 40% in the Pioneer 2 trial. As I was trying to bring home the point that we are not just trying to work on the glucose, we are not just trying to work on the weight, but we are trying to see if we can help the patient with a single molecule that works at several levels in a holistic fashion. Now, what is the scenario in the Asian patients? So I thought this meta-analysis from none other than Dr. A.K. Singh, who's one of our researchers, he looked at CV outcomes with SGLT2 and GLP-1 in Asian patients with type 2 diabetes. What you can see over here is that the 3-point MACE in CVOTs with SGLT2, and here are the 4-point MACE in CVOTs. What they concluded is that this meta-analysis found there was a significant reduction in MACE with GLP-1 receptor agents, but not with SGLT2 inhibitors in Asians. In fact, as far as even hospitalization for heart failure goes, or CV death, again, this was not seen with SGLT2 inhibitors in the Asians. This meta-analysis actually got us all pondering as to what is the differential signal in Asians, and we need larger trials with SGLT2s before we start preferring SGLT2s over GLP-1s in our patients, and is there an ethnic difference that remains to be established. So the current recommendation also, we don't have to worry about dosing as far as oral semaglutide goes. We don't, as you can see, that we do not have to use with caution. You monitor renal function, of course, but you do not have to worry about using these agents. Last but not the least, my able colleague already told you it's okay to have GU infections and reuse them, but certainly I would say you need to stay away from that and be very, very careful when you re-challenge with all the precautions he mentioned. He's already shown you the slide from the same article of Dr. Unnikrishnan that the ratio, the percentage throughout the country, depends on which data you look at, is about 5 to 7%, which is by no means a small number. And hence, what factors would you keep in mind besides cost when you start choosing between a GLP-1 agent or SGLT2 inhibitor? Clearly, GLP-1 agent is a better choice when ASCVD predominates, SGLT2 when heart failure predominates. Whenever MACE is the greatest threat or we need weight loss, you need to think about using GLP-1 receptor agents with a greater weight efficacy. Let me just show you why. Because now when you start using them, and more importantly, as he also mentioned, Dr. Phatak, that we need to think of the combined properties. If you use one versus the other, you will certainly miss something. But we need to stay here in the center, and all of us need to really become better metabolic physicians and start working on albuminuria and inflammation, whereby which we can give better quality of life to our patient. And therefore, this is the last summary slide, which kind of goes through all the things we spoke about. If you can see, I'll just conclude over here, that if you just use GLP-1 agents and you just use SGLT2, you will not get the bang for your buck that you're getting when you start combining these two molecules. And hence, it's time for us as clinicians to not think of diabetes and CV disease as separate things, but think about them as a continuum, and it's time to apply the evidence that I've just shown you. Thank you very much for your attention.
Excellent. I think both the speakers have done quite justice for their day. Let me just put a question across to Dr. Sanjeev Bhai, that if patient had a genital infection, you started on SGLT2 again, and again patient had an infection. So how long you will keep on re-challenging before switching on to something else?
Great question, Vivek. But the problem is genital tract infections most of the times occur because of the improper hygiene. If you have explained it very well, the infection rate goes down significantly. Of course, I don't mean to say that it cannot occur, but still, if we do not explain them properly, especially males, regarding the perineal hygiene or the foreskin hygiene, the infections will be recurrent. If patient is taking care properly, the infections are very, very less likely. And that is why you might have remarked that in person who has been circumcised, there is rarely any balanitis or balanopostitis, which means that proper hygiene is extremely important. In spite of proper hygiene, if the genital infections are recurrent, obviously we need to stop.
Like in this patient, if you want to continue with the SGLT2, why don't you suggest for a circumcision and then go ahead with that?
That is also a very good option, but very few patients would agree for that. That's why. Practically, it is difficult. Otherwise, it's a very good option that go for circumcision. And actually, in my clinical practice, there are patients who have undergone circumcision just for taking SGLT2.
Does the incidence of balanitis go down when you add DPP4 to these patients?
There are papers, and one of the studies suggested that inhibition of the fungal DPP4 by DPP4 inhibitors probably is the mechanism through which it would reduce, but in practical experience, I don't think so. In our study also in Genius, there is some reduction in the infection rate, but not statistically
Is it
significant.
proportionate to the serum sugar levels?
Yes. So higher the blood glucose level, higher would be the glycosuria and obviously the risk of
So in
genital.
DAPA CKD, DAPA HF trials, actually incidence of balanitis was as good as placebo.
Yes.
Because if you're not diabetic, probably you don't get it.
Dr. Rucha, in your exposition, like it was mentioned, oral GLP-1 RAs and CKD in an obese patient like this. Ideally, because so balanitis thing as a recalcitrant balanitis, of course, at times it recurs with whatever amount of challenges. So you have to shift to GLP-1 RA, you win in this case. But then otherwise, this guy deserves both because these are disease-modifying therapy. And this guy has diabetic kidney disease and is HFpEF also. And this oral semaglutide has not been shown to proven to ameliorate the progression of nephrosis. Of course, it's a good anti-obesity drug. So in this, and then all the trials, and they are going to be kind of foundational pillar for nephrosclerosis amelioration over and above SGLT2, RAS inhibition, non-steroidal MRAs. So after flow trial, probably injectable semaglutide, not the oral one. So the title was oral semaglutide. So where do you see this fix here in this scenario?
Works like this.
It's working.
Can I have?
Can hear.
Can you hear me? Yeah. So yeah, that's a great question for the audience. The data for CKD, is it as robust for oral semaglutide versus injectable semaglutide? So the reason we have kept it oral is because in India we have oral semaglutide available only. Hopefully in the near future, I mean, it has been approved for a while, so we'll have the injectables. Again, like I said, is we don't have enough ethnic data to suggest whether the oral, the GLP-1 versus the SGLT2, what differences we will see. Clearly with the SGLT2, we have all the good kidney data. There's no doubt about that. And the data, what you're pointing out with injectables, we have not really looked at large numbers. We have suggestions to show that there is, in the CLEAR-2 study, that they're going down for the oral semaglutide also, as far as real-world data goes for reducing microalbuminuria. So you can kind of extrapolate that data. But your point is well taken, and hopefully we should have the injectable preparations in a while.
This is extrapolation, and if you go higher,
Yes.
say 14 mg, if you are able to strive to reach that dose, it might mimic a lower dose of injectable semaglutide. As they said,
Absolutely.
0.5 mg still works there. Or sir, Pathak sir, if I want to give SGLT2 and somehow, so can I use 5 mg of dapagliflozin just a trade-off? Some SGLT2 better because being a disease-modifying therapy here.
Great. Well, with dapagliflozin with 5 milligram, glucose lowering will be there. It would be almost equal, but we do not have any cardiovascular data with 10 milligram. As against that, with empagliflozin, we have data with both 10 and 25 milligram, and in practice, myself, Kamal, a lot of our colleagues, we use 12.5, 25 half. Correct me if wrong, Kamal. So with EMPA, both high dose as well as half dose have very good data. With DEPA, 5 milligram, there is hardly any data supporting its cardiovascular benefits. For glucose, yes.
And then for disease, DKD and heart FPEF. This
Again,
guy.
for diabetic kidney disease
Some
also, the
SGLT2
data is
on.
mainly with 10 milligram
10
of
milligram.
DEPA
Of course.
or with 10 and 25 of EMPA.
Dr. Kamal, your opinion?
No, I agree. I think it's 5 milligram probably has little value. 10 of AMPA is still okay. 10 or 5 of DAPA is probably not such a great therapy to choose in such kind of a scenario. DAPA CKD did not have a 5 mg arm. It only had a 10 mg arm.
Question from audience.
Audience has played the quiz, and the question was which of the therapies actually has highest evidence of reduction in stroke and in the RCT, and the answer was semaglutide. Sanjay Parmar has already won a prize. Karthik has already won a prize. So Khushi gets it this time. Khushi Patel can come over. So this was the question, and this is the answer. Of course, we know between the options, pioglitazone was first to actually show its safety profile in such a case would reduce it. SGLT2s do, that they do not demonstrate significant reduction in stroke. Sulfonylureas have neutral effect. 16% reduction in stroke, and now we know from semaglutide and other GLP-1 analogs how it reduces. So one of the chairpersons to, yeah.
Ideally, this patient deserves both SGLT2
Absolutely,
and GLP.
absolutely.
So, sabka saath, sabka vikas.
Sabka saath, sabka vikas. This patient, I would put on a GLP-1 analog and then add an SGLT2 so that the balanitis does not happen with the sugar control.